Welcome to the IBUS-Ultrasound series. I'm Hyun Ji Lim, a radiologist specialized in pediatric and abdominal imaging at Suho Clinic in South Korea. I concurrently serve as a visiting professor at Severance Hospital. In this video, Basic Part 1, we're going to cover the key features of intestinal ultrasound in Crohn's disease from normal bowel anatomy all the way to validated scoring systems. This series is designed for medical professionals. Let's get started. Here's what we'll cover today. Section 1 begins with normal bowel anatomy. Section 2 covers the key sonographic findings in Crohn's disease. Section 3 introduces the two main IUS scoring systems, IBUS-SAS and SUS-CD score. And finally, we will discuss the limitation of current scoring protocols and why whole GI scanning matters. Let's start with Section 1, the normal bowel layer structure and reference thickness values. The normal bowel on intestinal ultrasound appears as a characteristic 5-layer structure with alternating hyperechoic and hypoechoic bands. From the rumen outward, the layer 1 is a hyperechoic interface between the luminal content and the superficial mucosa. Layer 2 is a hypoechoic and represents the deep mucosa, including the muscularis mucosa. Layer 3 is a hyperechoic and corresponds to submucosa, which contains connective tissue, vessels, nerves, and fat. This is an important landmark because it is often the thickest echogenic layer and can become markedly thickened and more echogenic in active Crohn's disease. Layer 4 is hypoechoic and represents the muscularis propria, while layer 5 is a hyperechoic and corresponds to serosa or adventitia. In practice, however, the innermost and outermost layers are often not clearly visualized on ultrasound. Mostly, what we usually identify is a 3-layer pattern consisting of the muscularis mucosa, submucosa, and muscularis propria. Once bowel word thickness is identified, the next question is, are the layers preserved or is there loss of word stratification? Word thickening with preserved layers is typically seen in active inflammation, often prominent submucosal edema, meaning layer 3 is markedly bright and thickened. The architecture is intact, which generally suggests active but less severe disease. On the other hand, loss of word stratification, where the distinct layered patterns are breakdown, indicates severe inflammation. This can be focal or extensive. This is a critical distinction in Crohn's disease. Loss of word layering is associated with a significantly higher risk of penetrating complications, such as fistula and abscess formation. Let's look at some actual cases. In the image on the left, the jejunum shows a normal anterior wall, but a thickened posterior wall. In the anterior wall, you can distinguish a typical black-white-black pattern indicating a preserved bowel word stratification. However, in the posterior wall, the wall layer can no longer be clearly differentiated. The thickened bowel appears hypoechoic, showing a darker echogenicity on ultrasound. This is another jejunal case. The bowel wall is thickened and normal layer appearance is also lost. The loss of wall layer may be focal. Can you see the dark color here? In this image, the 3 o'clock to 6 o'clock direction bowel wall lumen shows focal loss of wall layer. It does not involve the whole bowel layer, but it shows poor differentiation in bowel layer. Another case, thickened terminal ileum with diffuse loss of word layer. Loss of word stratification is not limited to the small bowel. It can also be seen in the colon. This is an ascending colon. The normal layered Appearance of the bowel wart is lost from 6 o'clock to 12 o'clock position, and mild hypervascularity is seen on Doppler imaging. The lumen is also focally narrowed too. This patient had a history of severe stenosis in the ascending colon associated with an inflammatory polyp and underwent endoscopic balloon dilatation about 1 year ago. This is another case involving the transverse colon, demonstrating a skipped lesion. The segmentally thickened bowel wart shows loss of wart stratification and hypoacuogenicity, mildly increased vascularity, and focal hyperacuic foci suggesting of ulceration are also noted. Colonoscopy confirmed the presence of several ulcers and corresponding mucosal abnormality. This case involves the rectosigmoid colon. The thickened bowel wart demonstrates the loss of normal wart stratification, hypoacuogenicity, and mild hypervascularity. Colonoscopy confirmed the presence of several ulcers and corresponding mucosal abnormality. This table is your quick reference card. However, bowel wall thickness alone should not be used as a sole indicator of inflammation. Assessment needs to be multidimensional, integrating other sonographic features. In some patients, active inflammation can be present despite relatively normal bowel wall thickness. For pediatrics, it seems obvious that they need another cutoff value apart from adults. There are many updated papers saying that we need to set a different, more sensitive bowel wall thickness threshold to children and adolescents. The most recent paper in inflammatory bowel disease, referenced on the screen, established a sex-weight stratified cutoff for terminal ileum bowel wall thickness in children. The key findings are boys age 6 and older, the normal upper limit of the terminal ileum bowel wall thickness is 0.27 to 0.3 cm. Girls or children weighted less than 40 kg, the optimal cutoff is 0.24 cm, which gives the best balance of the sensitivity and specificity. Additionally, pediatric Crohn's disease has higher rates of upper GI and proximal small bowel involvement, so whole GI scanning is especially important in children. IUS is the preferred imaging modality in pediatric IBD precisely because it is radiation-free, requires no sedation, and can be repeated at every clinical visit to monitor disease activity. Now let's move to section 2, the key sonographic findings in Crohn's disease. Here's an overview of the main sonographic features we will cover. We will go through skip lesion, asymmetric wart thickening, increased vascularity, mesenteric fat prominence, enlarged lymph nodes, ascites, and then the complications including stenosis and fistula. Among these findings, skip lesion, asymmetric wart thickening, and mesenteric fat prominence are characteristic radiology features of Crohn's disease. In this video, we will focus only on complications including stenosis and fistula. However, Crohn's disease can be associated with several complications, including stenosis, bowel wart obstruction, fistula, perforation, and abscess formation. The skip lesion is the hallmark feature of Crohn's disease. It refers to segmental bowel wart thickening with normal intervening bowel, meaning you will see an affected segment, then completely normal bowel wart, then another affected segment. This is what distinguishes Crohn's from ulcerative colitis or other bowel disease. Crohn's disease can simultaneously involve multiple segments, the terminal ileum, ascending colon, sigmoid, and then even the upper GI tract, with perfectly normal bowel in between. The practical tip is, when you find one lesion, don't stop scanning. Systemically evaluate the entire accessible bowel. Missing a proximal skip lesion changes the disease classification and management. This is the terminal ileum. There is no significant wart thickening in the distal terminal ileum. However, as we trace proximal part here, we can see a abruptly thickened bowel wart. The more proximal bowel then returns to the normal wall thickness. This finding represents a skip lesion, which is one of the characteristic imaging features of Crohn's disease. Skip lesion can also be found in the colon. This is the descending colon, and here you can see a segmental wall thickening with adjacent normal segments. Asymmetric wall thickening is another feature that helps differentiate Crohn's disease from other inflammatory conditions. In Crohn's disease, the inflammation is transmural and non-uniform, so one wall of the bowel lumen is often significantly thicker than the opposite wall. Contrast this with ulcerative colitis or other colitis, where the inflammation is mucosal and typically circumferential and symmetric. When you're measuring a bowel wall thickness, always check both sides of the lumen. Asymmetric wall thickening is a flag for Crohn's disease. In this case, the pelvic ileum segments demonstrate an asymmetric bowel wall thickening. The anterior wall shows mild wall thickening, while the posterior wall is more markedly thickened. Color Doppler assessment of the bowel wall vascularity is an essential component of intestinal ultrasound for the evaluation of inflammatory activity. It reflects neovascularization and active mucosal and transmural inflammation. In the IBUS-SAS scoring system, the color Doppler signal, CDS, is graded on 0 to 3 scale. A CDS grade 2 or higher is generally associated with endoscopically active disease and correlates with objective inflammatory marker including CRP, fecal calprotectin, and the SUS-CD endoscopic score. From a technical perspective, standardization of proof pressure is crucial. Excessive transducer compression can reduce detectable Doppler flow and result in a false negative interpretation. Therefore, examination should be performed with a gentle proof pressure, optimized gain setting, and a consistent scanning technique. This figure illustrates the grading of color Doppler signal according to the IBUS-SAS scoring system. Grade 0 indicates no detectable vascular signal. Grade 1 represents minimal vascularity characterized by the short, spotted signal within the bowel wall. Grade 2 represents moderate vascularity characterized by a confluent linear Doppler signals confined to the bowel wall. Grade 3 represents marked vascularity defined by a long Doppler signal extending both within and beyond the bowel wall into the mesentery. It is the key distinguishing feature from Grade 2. This color Doppler grading system provides a standardized method for assessing bowel wall vascularity and helps in evaluation of inflammatory activity on intestinal ultrasound. This slide compares the IBUS-SAS color Doppler grading system with the modified Limburg score. The key point is that original Limburg score combines two findings, bowel wall thickness and Doppler vascularity. For example, if the bowel wall thickness is normal and there's no Doppler signal, both systems score it as 0. However, if the bowel wall is thickened but there's no Doppler signal, the modified Limburg score becomes 1 because it includes bowel wall thickening in the score. In contrast, in the IBUS-SAS system, the Doppler component remains 0 because IBUS-SAS evaluates bowel wall thickness and Doppler vascularity separately. So, for vascularity alone, IBUS-SAS uses a simplified color Doppler classification derived from the modified Limburg score. On intestinal ultrasound, creeping fat appears as hyperechoic and thickened mesenteric fat wrapping around the inflamed bowel segment. This is not just a nonspecific surrounding change. In Crohn's disease, creeping fat reflects pathologic mesenteric adiposity and is closely related to transmural inflammation. It can also correlate with disease severity, especially when it is prominent around the thickened and inflamed bowel segment. In the IBUS-SAS scoring system, this parameter is called IFAT. It is graded as 0 when absent, 1 when uncertain, and 2 when present. One important point is that mesenteric fat prominence may persist even when luminal inflammation improves. So, when we assess Crohn's disease with intestinal ultrasound, mesenteric fat prominence should be evaluated together with bowel wall thickness, Doppler vascularity, and bowel wall stratification. This image shows a thickened mesenteric fat surrounding the inflamed small bowel. Normally, the small bowel loop may lie close together or appear clustered. However, in Crohn's disease, the prominent mesenteric fat can be seen between the bowel loops. This thickened mesenteric fat may separate the adjacent small bowel loops and make the distance between them appear wider. So, when we see hyperechoic thickened fat around an inflamed bowel segment, especially when it separates the bowel loops, this can be an important supportive finding of transmural inflammation in Crohn's disease. Next finding is an enlarged mesenteric lymph nodes. In Crohn's disease, reactive lymph nodes are often seen around the inflamed bowel segment. On ultrasound, lymph nodes with a short axis diameter greater than 5 mm are generally considered enlarged. When enlarged lymph nodes are seen together with a bowel wall thickening, they can support the presence of active inflammation. However, if the nodes are very large, atypical, or widely distributed, other causes such as tuberculosis or lymphoma should be considered too. This slide shows ascites adjacent to thickened bowel loops. On ultrasound, ascites appear as a free, anechoic fluid around the inflamed bowel. Even a small amount of free fluid can be clinically meaningful in Crohn's disease because it may reflect significant transmural inflammation. If the fluid is loculated or if it is associated with severe pain or systemic symptoms, we should also consider complications such as perforation or abscess. So ascites should not be overlooked, especially when it is seen near the actively inflamed bowel segments. Now let's move on to complications. In this video, we will briefly touch on key complications, but we will cover them in a greater detail in an upcoming video where I will share a dynamic clips to give you a clear and more comprehensive look. So please stay tuned. Complications starting with stenosis. Compared to other imaging modalities like CT or MRI, ultrasound is an excellent modality for the early detection of stenosis, primarily because it allows for the assessment of bowel motility. Since the bowel is a dynamic organ, evaluating it on static CT or MR images can be challenging as it is often difficult to differentiate between simple contraction and true luminal narrowing. In contrast, ultrasound enables a continuous, real-time evaluation of the suspected segment. A diagnosis of stenosis can be made when there is a narrow small bowel diameter accompanied by proximal fluid or gas distension measuring up to 25 to 30 meters or more. A color Doppler signal helps identify subtype 2. Regarding stenosis, we can categorize it into two types, inflammatory and fibrotic stenosis. This distinction directly changes management. An inflammatory stenosis shows active wall thickening with increased Doppler signal. It responds well to medical therapy, biologic, or steroids. A fibrotic stenosis is an irreversible stricture with an absent or minimal Doppler. It responds poorly to drugs and typically needs dilatation or surgery. Most real-world strictures are mixed. Both components coexist. To avoid ending up in surgery, catching and treating inflammatory stenosis early is absolutely crucial. Timing is everything here. Let us examine the schematic representation of bowel stenosis in Crohn's disease. In longitudinal view, the stenotic segment is combined with an upstream bowel distension characterized by a dilated rumen exceeding 25 to 30 meters or more. The cross-sectional view in the middle highlights the distinct pathophysiological differences. The inflammatory subtype present with a thick, inflamed wall and hypervascularity. Conversely, the fibrotic subtype show a marked fibrosis with a tiny rumen and an absent or few of color Doppler signals. I would like to present a case involving a patient with a history of recurrent small bowel obstructions. The initial ultrasound image on the left demonstrates the pelvic ileum. It reveals localized inflammation characterized by asymmetric word thickening, where the anterior word remains thin while the posterior word is significantly thickened. Proximal to this inflammatory lesion, there is no combined peristenotic bowel distension. While this indicates chronic structural remodeling of the bowel, the current active inflammation appears minimal at this baseline stage. However, during a follow-up ultrasound performed 2 months later, we observed exacerbated inflammation in other bowel segments compared to the baseline exam. Also, in this specific lesion, the bowel showed increased edema, prominent mesenteric fat, increased vascularity, and development of upstream fluid distension. This indicates an acute flare-up. It is critical to note that although there was a chronic structural change in the pelvic ileum, it was not initially mainly a stricture or fibrosis. However, when an acute inflammation was superimposed on the pre-existing chronic change, it leads to severe passage disturbance. 7 days following this ultrasound examination, the patient went to the emergency department with acute abdominal pain. The patient's inflammatory lab and corporotactin was normal, but patient had severe symptoms. For further evaluation, MRI was performed and the MRI confirms that acute or chronic inflammation in the pelvic ileum causing a small bowel obstruction. Although the obstruction was triggered by an acute flare, the initial scan on the left clearly demonstrating a pre-existing chronic structure changes. Given the patient's history of recurrent obstruction at this exact site, surgical intervention was deemed inevitable. Therefore, an elective planned strictureplasty was performed. In clinical practice, strictures in Crohn's disease cannot always be strictly categorized into purely inflammatory or purely fibrotic types. In most cases, these two components coexist in varying degrees. I believe the crucial role of an IBD specialized radiologist is to provide an accurate assessment to determine whether the lesion can be managed medically or if surgical intervention is required. The second complication is fistula. On ultrasound, a fistula looks like an hypoechoic tract connecting bowel to an adjacent structure. On color Doppler, there's no internal flow, and the tract may contain echogenic foci from gas or debris. This can be enteroenteric, enterovisceral, or enterocutaneous. Often, fistula is associated with adjacent obstruction, abscess, or inflammatory mass. This is an enteroenteric fistula in the pelvic ileum. The fistula usually develops after a long-standing inflammation between adjacent small bowel groups. On ultrasound, fistula typically appear as a linear or star-shaped hypoechoic tract connecting the involved bowel segments. Once the fistula is identified, it is important to carefully evaluate the surrounding area for associated complications such as bowel obstruction, abscess formation, or an inflammatory mass. Again, we will cover the details of these complications in the upcoming video, so please stay tuned. This section covers the two main IUS scoring systems, IBUS-SAS and SUS-CD score. IBUS-SAS and SUS-CD overview. IBUS-SAS is the International Bowel Ultrasound Segmental Activity Score. It uses 4 parameters: bowel word thickness, color Doppler signal, word stratification, and mesenteric inflammatory fat, combined in a regression formula scale from 0 to 100. A score above 48.7 indicates active disease, and it has excellent inter-observer agreement. SUS-CD, the simplified ultrasound score, is simple. Just two parameters, word thickness and Doppler, summed simply on a 0 to 5 scale, with a cutoff of 3.52 for active disease and strong correlation with the endoscopic SUS-CD. In short, IBUS-SAS is comprehensive and SUS-CD is fast and practical at the bedside. Let's break down the IBUS-SAS formula. The score equals 4 times the word thickness plus 15 times IFAT plus 7 times the Doppler signal plus 4 times word stratification. Word thickness is entered directly in millimeter. So 5.5 millimeter contributes 5.5. The inflammatory fat is scored 0, 1, or 2. The Doppler signal 0 to 3 by the modified Limburg pattern. And the word stratification 0 to 3 from normal to focal loss under 3 cm to extensive loss beyond that. Notice that IFAT carries the heaviest weight at 15. As for interpretation, roughly 24 to 27 and above indicates active disease, and 40 or higher correlates with moderate to severe endoscopic disease. Both scores evaluate the same 7 segments: terminal ileum, cecum, ascending, transverse, descending, and sigmoid colon. Each segment is scored independently. Depending on the protocol, you either take the most affected segment as representative or sum across the segments. And the rectum is excluded in most protocols due to its technical difficulty. However, an important limitation of this both IBUS-SAS and SUS-CD score is that they do not include esophagus, stomach, duodenum, and most of the small bowel except terminal ileum. To summarize, there are 5 take-home messages. 1. The normal bowel wall has 5 layers, and loss of the layering indicates severe transmural disease. 2. The key Crohn's disease findings are skip lesion, asymmetry word thickening, increased vascularity, prominent mesenteric fat, and enlarged lymph nodes, with stenosis, fistula, and abscess as a major complications. 3. IBUS-SAS with 4 parameters and excellent reproducibility, and SUS-CD with 2 parameters and a simple sum are both validated scoring tools in IUS. 4. IBUS-SAS and SUS-CD evaluate terminal ileum through the sigmoid colon, but the stomach, duodenum, most of the small bowel except terminal ileum, and rectum are left out. And 5. A whole GI ultrasound from stomach to rectum gives the most complete assessment of disease beyond the standardized protocol. Thank you.